I Hate Politics is a podcast about a human activity we love to hate. I'm Sunil Dasgupta. The reversal of Roe v. Wade, the Supreme Court decision that legalized abortion across the country in 1973, has turned the clock back 50 years to where abortion is now only available state by state, depending on local politics and legislation. Maryland today finds itself as the southernmost state on the eastern seaboard to offer fully legal abortions. And the state's providers are expecting women from other states where abortion is illegal to travel here for reproductive health services. Washington, D.C., where abortion is still legal, is more precarious since the city is subject to congressional authority, which, if it swings Republican in the next couple of elections, could very well end abortion services there. For this episode, I asked Maryland delegate from Montgomery County, Ariana Kelly, what's being done. Kelly is one of the legislative leaders in the state pushing for a variety of measures to protect the provision of reproductive health services, not just for Marylanders, but also for out-of-state patients who might be traveling here in the future.
Let them stay your girl. You'll always have your own. But take something for granted and it will be taken from you. This I've come to know.
If you're new to the show, I Hate Politics is a podcast about our neighborhoods, workplaces, schools, and streets, and our local governments as they function in diverse and democratic societies. This means our politics are messy, dirty, sometimes corrupt, with often self-serving politicians, but no matter how much we may hate politics, we are never exempt from it, even when we refuse to participate. In fact, the purpose of politics is to keep society functioning precisely when we don't agree with each other, like now. It is my hope that this podcast will help those who feel left out reconnect in our local communities. Music for this episode comes from the Treading Lemmings, a Rockville-based Britpop band in the genre of the Smiths. Their music is available on ReverbNation.com.
I gave yesterday. And if you want to hear my take, let there be care. Bust off your day. She's there, I say. Please won't you share? Come share my umbrella of shade.
At the top of the news this week is a I Hate Politics announcement. We built an interactive voter guide to help you cut through the clutter of campaign advertising and mailers and claims and counterclaims from candidates. Called IHP Bot, the tool is available free online at moco2022.ihppod.com. The link is also available on I Hate Politics social media, which is at IHP Pod. IHP Bot, the tool, is intended to boost voter turnout by making it easy for voters to make choices between candidates, often in crowded and undifferentiated races. Even when voters know their choice for governor or county executive, picking 5 county council candidates, 4 Board of Education candidates, 4 judges, a sheriff, and a clerk of the court. Few voters know what these positions are, let alone make educated choices. The sheriff in Montgomery County is not the chief of police. The chief of police is appointed. The sheriff is the head of county jails. Since it is about picking candidates, worth pointing out that no campaign, candidate, or interest group participated in or is associated with the creation of IHP Bot. All the background research comes from the work we do to put the podcast together. The last few days before the election tend to be a whirl, which turns increasingly nasty. Most controversially, in Montgomery County, the Maryland Senate Democratic Caucus sent out a mailer on behalf of incumbent Jeff Wallstreicher that called his opponent, Mac Sokol, abrasive, profane, and wrong for us. To illustrate the matter, they picked two tweets from Sokol using the F word. The Senate Democratic Caucus sent a second mailer also attacking Sokol. The school board races are another place where the invective is high, in part because they are being contested by some right-wing candidates, aligned with Moms for Liberty, the Trump-inspired group that helped Republican Glenn Youngkin become the governor of Virginia. Given Montgomery County's demographics and political leanings, 3/4 of the county is registered Democrats. It is unlikely that any right-wing candidates will actually win, but the campaigning, especially on social media, is heated and exaggerates right-wing influence. It is hardly uncommon for legislative caucuses to support incumbents, but the mailers, such as against Mac Sokol, have created quite a consternation. Incumbent Jeff Wallstreicher, it seems, had rubbed several prominent citizens in his district and elsewhere in the county the wrong way, refusing to take meetings, not joining public events, and choosing positions on policing, for example, that were at odds with his district's more liberal voters. The Women's Democratic Club of Montgomery County shot back with a letter criticizing the Maryland Senate Democratic Caucus for jumping into the primary race rather than focusing their energies on winning Republican-held seats. Maryland Senate President Bill Ferguson's PAC is believed to have contributed $500,000 in part to fund the anti-Sokol mailers. All of this raises the question, does negative campaigning work or does it turn people off? The street wisdom on the question is not vastly different from the scholarly one, but stops halfway. Ask anyone on the street and they will tell you that negative campaigning turns people off from those who practice it. But ask political scientists who study these things and they will tell you that the answer lies in understanding who it turns off. Negative campaigning never changes the mind of those who have already committed to candidates, but it can depress turnout among the undecideds. And if a candidate is playing to the middle, they are vulnerable to negative advertising. And usually the reaction counter-reaction cycle it sets up depresses turnout among undecideds even further. So, does it make politics a bad thing? Why do soccer players take fake falls? We like neither, but we do go back to the game, right? I'll be back with Maryland delegate Ariana Kelly.
Such a cold on a night when nothing was on. Had a feeling about it, couldn't quite explain.
Ariana Kelly, welcome to I Hate Politics.
Thank you so much for having me.
What are the immediate post-Dobbs impacts you're seeing in Maryland and in the Washington, D.C. region?
And we're seeing a lot of concern, obviously, a lot of passion, a lot of frustration, and also a lot of fear. There's tremendous concern for people who are in states that are not protecting abortion rights. I am hearing, what can we do? How can we help people? It's very important, certainly to my constituents. I have heard from so many of them that we be leaders in that space. But there's also real fear about the impact of a potential upcoming federal abortion ban or a Supreme Court that just decides, that fetal personhood is a real thing. It's I think, shaken people to their core. I think a lot of people were really shocked and did not think that this would actually happen.
Sure. Are you actually seeing a surge of patients already? Are we seeing that?
Sure. Well, so our clinics are seeing an increase in appointments. We've been seeing that since Texas banned abortion with SB 8. They virtually banned abortion. And we've since then seen a couple of patients every week from Texas. Obviously, there are more states passing bans right now as we speak. And we're seeing an impact already in our clinics. We're expecting, when this is all said and done, that about 25% of abortion providers are going to close in the next few months. With Maryland being the southernmost of the safe states, we are expecting to see patients from Alabama, Arkansas, Missouri, Ohio, Oklahoma, South Carolina, South Dakota, Tennessee, Texas, of course, West Virginia. So, it's a lot of pressure on our healthcare providers.
Sure. So do you have a number or for what capacity we actually have, or is that not something that is known or findable?
Well, it's interesting, right? Because the legislation that we passed this year was intended to increase our capacity. And we were doing that for Maryland patients, right? We
Right.
already had a capacity problem in Maryland. 2 out of 3 of our counties didn't have a single provider. So that's our starting place. So it's a challenge. The number of providers we have in Maryland has been decreasing over the years while our population has been increasing. So we already had a problem to begin with. And now this, of course, at the federal level is really exacerbating that.
I just want to get a sense. I mean, when you passed that bill, in what was it, April, about increasing capacity, what was it at that time, and what were you intending it to be? Do you have a sense of that?
Yeah, absolutely. So we were trying to address 2 different sets of problems, right? We didn't know for sure that Roe was going to be overturned, but we thought it was really likely. But we were working with a legislature that was skeptical, right? There's this sort of cried wolf thing that's been happening for the last couple of decades, where people say, "Oh no, the Supreme Court's going to ban abortion and overturn Roe v. Wade," and people are like, "Yeah, I heard that before." And Maryland had not actually done an expansion of abortion access or any abortion-related legislation for 30 years. 30 years. So we had to convince the legislature that this was the year we had to do it and that there was a real reason to do it. So we really looked into Maryland's existing capacity. We identified this problem, that there was a huge shortage of providers, especially in our rural areas, and a shortage of providers that were able to provide culturally congruent care for diverse communities also, which is a problem we wanted to solve. We also identified that there were tremendous financial barriers in Maryland. Medicaid policy was really outdated and insurance policy was spotty, and a lot of people were delaying care because of really high deductibles and copays. So we wanted to solve all of those problems for Maryland residents. But in doing so, we also knew that we were going to likely have this problem coming in the near future of even further demand for appointments and even further need for financial support for out-of-state patients. So a lot of the financial measures in the bill that we passed, the Abortion Care Access Act, that requires insurance coverage for abortion care with no cost sharing, no deductible, that ensures that Medicaid patients are treated equitably. They also have equal coverage to private insurance with no cost sharing and no deductibles. They don't have to justify their need for an abortion in some sort of humiliating way just because they're low income. Those financial measures are going to help us take pressure off of the abortion funds in Maryland that do charitable support for people who need abortions. So that frees up dollars to help people from out of state come to Maryland for care if they need to. So we're solving problems for people in Maryland while also predicting that we're going to need to solve some problems for the out of state community as well.
Okay. So there isn't, I take it then, any numerical way to understand this. I want to ask you then, so you had this idea that you were going to allow advanced practice clinicians to perform abortions. And that's a way of really expanding access, right? Because, the shortage is not just in the clinics, but also in the staff that is able to do it. What do you think? I mean, what was your thinking with that, and what kinds of effects you're hoping to see?
Sure. The advanced practice clinicians, let's be clear about who they are: nurse practitioners, nurse midwives, and physician assistants. These are folks who are already working in Maryland, already providing labor and delivery care, miscarriage management care, contraceptive care. They're certainly qualified to provide abortion care. We had a a restriction on their ability to provide only abortion services on the books in Maryland. It's really outdated. It's from a time before these professional provider groups were really active in Maryland. It needed to be updated because we had this shortage of providers, but also because there was no policy reason, no healthcare reason that we should have this ban on the books. It was political in nature only, meant to limit our number of abortion providers. And in fact, two important points, right? Maryland's OBGYNs, the doctors, weighed in strong support of this bill. This was their top legislative priority. You never see that, right? You never see doctors say, sure, let's give these advanced practice nurses extra authority. That's not how healthcare usually works. There's usually more of a turf war situation where people are saying, no, that's my role. No, that's my role. But here we saw collaboration because the OBGYNs have been so concerned about the shortage of providers and the lack of access to care we have in Maryland. And they are so confident that it is perfectly safe for these advanced practice clinicians to be providing care in Maryland. The second thing that I think is really interesting to note is that these professional groups that we're expanding to be authorized to provide care are overwhelmingly women, right? Nurse practitioners, nurse midwives are more than 90% female, physician assistants are more than 60% female. And what we have found is that women are really, really interested, committed to, passionate about providing access to reproductive health care services. So I just think that is worth noting, in particular because of what Governor Hogan used as logic to justify his veto of this bill, saying that he was worried about the quality of care being reduced, which is ridiculous because the OBGYNs were not worried, and I trust the doctors more than I trust Dr. Hogan on this issue. And it's a little sexist, in my opinion.
Sure. No, I understand. So you also put aside something like $3.5 million for more training. Is that training at the top, for advanced practice clinicians, or at the bottom to, new nurses or, more nursing students? Where is that going?
The 3.5 million will go to any licensed clinician who has abortion care in their scope of practice who wants to provide abortion care. So what that means is it's going to go to doctors, it's going to go to nurse practitioners, physician assistants, nurse midwives. You may be surprised to realize this, but even now, today, there are a lot of doctors in Maryland who aren't providing abortion who would definitely benefit from this abortion training and who want it. I've heard from them. They've called me. And in the future, and this is stunning, in the future, 44% of OBGYN residency slots are in those states that will have banned abortion. So almost half of the future OBGYNs who are graduating won't have access to abortion care clinical training. So we absolutely have to close that gap.
So don't you think the issue may be with the med schools and nursing schools rather than, I'm not sure I understand.
It's a both and. We can't solve what the med schools and the nursing schools are doing in Mississippi. We have no control over that. I wish we did. Right. And you don't get to pick necessarily where your residency is, but you can choose to practice in Maryland. But in addition to that, Johns Hopkins School of Nursing has already announced that they're going to include this training in their curriculum for nurse practitioners. We're working in partnership with Maryland's educational institutions to make sure that they are, as up to date and expansive as possible on clinical training as well. So It's both and, right? Our existing infrastructure needs to be doing this and we need to supplement it.
Right. I know that you have said in the past that, most of our providers are in the Baltimore-Washington corridor, and that there isn't, for example, capacity in Western Maryland, where I imagine there would be some amount of surge because, West Virginia is going to ban. Right. Yeah. So are there any special geographical things you have done in order to meet that sort of upcoming need?
So it's a really, really excellent question. A couple of different answers to that. So, the Department of Health, when they get the training program up and running, is going to be able to prioritize based on those needs. They are obviously have a delay in that getting that program up and running because Governor Hogan has refused to release the funds. So that's a huge problem, particularly because obviously right now is where we're beginning to see the increased demand. Getting a training program up and running would be really critically helpful. That being said, I don't make Governor Hogan's choices for him, and we will get that clinical training money released by next year. But in addition to that, the provider community that exists already in Maryland is already working really diligently on this issue. They're working really hard on expansion and to deal with the influx, and so they're sort of working to fill in the gaps around what the state isn't doing. So geographic access is one of the top priorities for that community. And as I was working with them during the passage of this legislation, I heard some just really heartbreaking stories. One nurse practitioner came to testify, and she told us about her patient and the barriers that she had to go through. She was on the Eastern Shore, and her patient needed to get abortion care, and she could not get to Baltimore. And she had several children, and I think several jobs, and she just told us this story about the challenges and how much more burdensome and more expensive it is for her patients on the Eastern Shore. And that nurse practitioner is now going, I'm cautious about what I'm saying because, and I think this will come up in your questions later, people who provide abortion care can become targets. So I'm not going to say to you, guess what? So-and-so in XYZ town is about to start doing abortions.
But so okay, geographically, what about sort of Southern Maryland? I mean, are we, I would imagine if Governor Youngkin has his way, I think there'll be a problem there. And, I do also want to ask about Montgomery County, which is both home to you and me.
Sure. I mean, the model for the Abortion Care Access Act is going to help people who are in or near all of the counties in Maryland, right? By a year from now, every county in Maryland is going to have an abortion care provider, at least for first trimester care through medication abortion. The way the model I expect will work in Maryland is that, we're going to be training and ramping up capacity for medication abortion, which is accessible up to 10 weeks in everyone's local community. So, your regular primary care provider, your OBGYN you go to for your annual pap smear, your trusted clinical provider who provides you with your birth control prescription, that person, right? Mm-hmm. In the perfect world, that person is able to provide you with abortion care in the first 10 weeks. It's perfectly reasonable. It's perfectly safe. It makes a lot of sense as long as it's something your provider wants to be doing. I've been hearing from a lot of providers that they do, particularly in this new context. And I'm hearing from a lot of patients who are saying, well, why would I go to a provider who chooses not to? So there's going to be pressure on them as well, right? Mm-hmm. And with that, then you reduce the burden on clinics, and you reduce stigma, right? Instead of having all patients go to a standalone clinic with a bunch of protesters outside where we can harass the patients, and that model that just sort of reminds any patient, you're a naughty, naughty girl, right? Right? We want to roll that back and be like, hey, abortion care is healthcare. There's no reason why I can't get a safe medication abortion through my regular reproductive healthcare provider. And that sort of flips the script a little bit, but it also really helps free up the appointments for the more complicated procedures that may be later in pregnancy or have other medical complications, so they're not eligible for medication abortion, for the specialized abortion providers.
What about being able to mail out Plan C to out-of-state patients from clinics within Maryland? Is that legally possible? What is our situation there?
Super interesting question. So healthcare in general is governed by the law of the state where the patient lives. So we're currently working to figure out what we can do and how we can help people in other states. It's definitely a top priority for me and for the legal community that is supporting the providers. So we're working to sort of better figure out what states we can work with in that capacity, what states we cannot. And that legal landscape is obviously changing rapidly. I just got a text from a colleague who told me about legislation in South Carolina that is just like a stunning overreach. It says new abortion ban bill introduced in South Carolina would prohibit anyone from telling a pregnant woman that she could go to another state for an abortion, prohibit anyone from driving her there, and prohibit a website from providing information about abortion. So that obviously doesn't deal with the U.S. Postal Service, but it does say that other states are going to be gunning for us, right? And that when I talk to our providers, and this breaks my heart because I truly believe that our abortion providers are healthcare heroes, right? Have been putting themselves on the line. 11 abortion providers or clinician staff or volunteers have been murdered in the last couple of decades, right? They've dealt with bombs, they've dealt with vandals, they've dealt with constant protesters and harassment, not calm, gentle protesters, aggressive harassment. They've been targeted. Their children have been targeted. Even I, as a legislator, just introducing legislation on this issue, has been targeted and received really violent and vulgar, really disgusting and threatening phone calls and postcards. It's scary, right? And so I think that one of our top priorities in Maryland this year is going to be protecting our clinicians from this threatened legal action that we're seeing these other states try and really overreach, both for clinicians that are working in Maryland and patients who might be coming to Maryland.
I'm a little bit flabbergasted right now because you said they don't want a website to provide abortion information to women in South Carolina. I mean, how does South Carolina have control over that? There could be a website run out of Denmark and they would have access to it.
Well, and South Carolina doesn't have control over the U.S. Postal Service, and South Carolina doesn't have control over what the FDA approves. There's a lot South Carolina doesn't get to control, but they're still trying to. And they're testing. And that is terrifying for our providers. And that's the point, right? This movement has been a movement that has used terrorist tactics for decades. And this is no different. We're seeing legislative and lawsuit terrorist tactics that are meant to scare people out of providing abortion care, right? They're trying to scare them by making them think that they're going to go to jail one way or another, or if not, they will bankrupt them through lawsuits.
Do you have a sense, I think, of this extraterritoriality, which is sort of now associated with state law? At federal level, there is some extraterritorial laws. For example, the international corruption law, right? So we want our law to apply even when our companies are doing business abroad. But, for states to act extraterritorially, is that just completely new? Or, I mean, do you know?
It's certainly new to me. It's stunning. And I'm both flabbergasted by it, but also really, and I'm not alone in this. This is something I talk to my colleagues about quite regularly, committed to figuring out how to put a stop to this. It's nonsense. In Maryland, we don't try to overreach towards these other states. One of the questions that you were going to talk to me about, I think, had to do with our insurance law provision, right? We control Maryland insurance law. We cannot tell South Carolina that they have to cover abortion in their insurance law. That's not how it works. I wish it were. I wish that it were, and then I would do it. But
all right, but imagine this, right? So maybe a South Carolina woman is visiting Maryland, and maybe she has an abortion. Now, can the provider charge South Carolina insurance or South Carolina-based employer-provided insurance for that service?
No, absolutely not. The way our law works, you have to be under an insurance plan regulated by Maryland. So not even every Maryland resident would qualify.
That's right.
You have to be in a Maryland regulated insurance plan.
And
same with Medicaid. It has to be Maryland Medicaid that you're covered through, not some other state's Medicaid.
But even more broadly, say there's somebody traveling on work, right? For example, that comes to Maryland and has a complication with her pregnancy, and they have to make a decision. And so they make the decision, they abort the baby, and then can that provider then charge South Carolina-based insurance for that service, or which is what would happen. Say I broke a leg in California.
Right.
Right.
That's a really good question. I haven't heard that raised yet, but I am sure. I mean, obviously, a lot of these insurance companies have their own, internal policies. I don't know that the South Carolina law would be structured to prevent them from paying the bill. But I could certainly see anybody with a political agenda choosing not to. There's this example out of Missouri from yesterday, stunning. The Supreme Court decision came down, and there's a hospital system in Missouri with a religious affiliation, and I heard two things about them. The first was that there was a woman who came in with an ectopic pregnancy, and her treatment, which she needed, was a DNC, was delayed while it went through, several rounds of different lawyers before she could get approval, which is extremely dangerous for a woman's health, extremely dangerous. But the second thing, which was even more stunning to me, because we've heard of these delays with ectopic pregnancy care before, was that they issued a statement saying, as a result of the Supreme Court ruling, St. Luke's Hospital will no longer provide emergency contraception. That's Plan B, not Plan C, right?
Mm-hmm.
Postcoital, a couple days after exposure, contraception to rape victims, because our lawyers have determined that's abortion. Wow. In Missouri yesterday. And there was such public outrage. And the other hospital systems in Missouri were like, our lawyers didn't say that. What are you doing, cray-cray? Right? And they rolled back their policy after so much public pressure. But this just shows you that, it's not always about what's written in the law or even what's written in the Supreme Court opinion. If people have a political agenda, and on this issue, certainly there are lots of institutions with political agendas, they will really stretch it. They will work hard to expand on their own goals.
Okay. Let's talk about the big issue that I think we will have to face as Maryland deals with the surge, is how do you protect your clinics and your providers from protests, but also violence, which what is your thinking about that?
It's interesting that you say this, because certainly in the past, that would be my biggest concern, particularly in the recent past, a few months ago when I was putting in this legislation, and I told you I was getting threats in my office, and I know what our providers go through. And I was very, very worried that after this decision happened, we would really become a target. People from all of these other states, protesters from all of these other states who've got nothing else to do now because they've banned abortion, will come here to our limited number of clinics in Maryland. I was terrified about that. That was my number one concern. But now, having talked to the providers, and they, unfortunately have been dealing with this for years. This is not, the violent protest fear is not a new one for them. What's new for them is this fear of legal action. Right. That's terrifying. It's terrifying because it is so unclear, and because it has been proven, I think, but from my perspective, that the courts can't be trusted. And so there's not a lot of logic to apply. You can try to comply with the law. You can read a statute like South Carolina seems to want to pass, and on its face be like, there's no way that's enforceable, but there's just so much fear right now around what is potentially going to happen to providers from these out-of-state actors who have as their primary political goal to put these folks out of business.
So their fear is that in Missouri, they will sue a Maryland provider and put them out of business that way. Is that the fear?
Yeah, absolutely. And put them out of business, bankrupt them personally, lose their medical license. There's a lot of fears in that space. And I understand it because if you read these ideas that these folks are coming up with, and they don't read as enforceable or constitutional to me or to Brett Kavanaugh in his concurrence. But I don't trust the court. So it's scary. We're going to do in Maryland absolutely everything we can.
What can you do?
Well, we have a very strong attorney general right now. My assumption is we will be electing a very strong attorney general for next year. Mm-hmm. I think at the state level, it is very, very important, much more important than ever before in the last 30 years that we elect a pro-choice governor, because a lot of these decisions are made at the agency level, and the Board of Physicians and the Board of Nursing, they already have been handling sort of frivolous complaints against our abortion providers for years. If the politics really ramps up in that space, we need to know that we don't have biased people being appointed to the Board of Physicians, right? Who have a political agenda in this space as well. It's not just about what bills someone might veto. That's where we were last year. That's not where we are anymore.
Okay. So have you talked to the American Medical Association about, they run the medical licensing. So, surely they understand what the problems are.
Absolutely. And, the issue is you have to, we are obligated to investigate every complaint, and we do. And I have gone through, the public records of any complaint over the last 20 years, because I wanted to be prepared for the floor debate, because you will hear this rhetoric come out of the anti-choice community in Maryland from some of the legislators who are opposed to abortion rights. And I wanted to know what was true and what wasn't true. And pretty much everything they said was not true, thankfully, because they was.
How many complaints are we talking about in the last 20 years that you looked through? How many? Like, is it in the tens or the hundreds or the thousands?
Oh, no. In the tens, dozens, in the dozens. But my concern is that might ramp up.
Do you think that the state will have to make some capital spending to build out some of the clinics and things that you're looking at? Or is that going to be left to the private sector to do, and you provide the other sort of insurance and all that kind of support?
I wouldn't be surprised. Our state has for a long time supported capital funding for community health services, and our state has shown a demonstrated commitment now to acknowledging that abortion is part of healthcare, right? So we do really need to ensure that providers are going to have capital funding if that's what they need.
You mean state-run community health centers?
Any sort of community health services. We can provide capital funding for all sorts of things. And we have a new grant program called Pathways to Health Equity. I don't know if abortion care is allowed to be covered in that, but if not, it should be expanded. The equity issues related to abortion access can't be overstated, right? Who are the people who need access to abortion care? Low-income women. They are 5 times as likely as affluent women to experience an unintended pregnancy. 75% of women seeking abortion are low-income women, right? There's a reason that Janet Yellen and Elizabeth Warren are so alarmed about this. This is not just going to have an impact on individual human beings. This is going to have an impact on women's rights and the economy and workforce participation. Women's workforce participation hasn't rebounded yet from COVID, and we're doing this now to women. It makes no sense at all, right? There's issues related to women's retirement security, right? Already 2 in 3 seniors who are living in poverty are women. It's going to get worse if they can't access abortion care earlier in their life. It's just what the data shows. It's just clear, right? We know that domestic violence and violence against pregnant people is likely to increase, and murder is already the top cause of death for pregnant women, right? And Black women are 8 times as likely to be murdered by their partners when they're pregnant. Right. And so none of this is going to get better with people having forced pregnancies. We haven't even talked about the just atrociousness of women who are pregnant as a result of rape and what that's going to do, or the injustice of the fact that there's zero overlap between states like Maryland, which have both access to abortion care and paid family leave, and those 26 states that are banning abortion.
I want you to leave me with some optimism now.
Optimism. Okay. How can I help with that? Well, we did pass a paid family leave bill in the state of Maryland, and we have been investing in childcare in the state of Maryland.
Ariana Kelly, thank you for coming on I Hate Politics. Good luck as you try to sort all this out, and please come back.
Thank you so much.
Drunken buzz, much like any other. I can play better than this one, that's all. Like a halo grape shot, he hit the ceiling. The ginger man really shook the walls. We've been looking for something. This was surely.
What lessons can we draw from my conversation with Maryland delegate Ariana Kelly, who has led the effort to get the state ready to be an abortion safe haven? First, if Governor Youngkin in Virginia has his way, Maryland may very well become the southernmost safe haven state on the eastern seaboard. That is some awesome responsibility, not only in capacity building for abortion services, but also the subsequent protection services the state will need to provide if anti-abortion protesters decide to come here. Second, the threat of violence isn't even the greatest concern, as Ariana Kelly points out. Abortion providers in Maryland are really fearful that anti-abortion states will pass extraterritorial laws that deprive them of their practice, bankrupt them personally, and even take their medical license. It is unclear how appellate courts might rule in cases where Maryland's pro-abortion law and another state's anti-abortion law face off over specific providers. It is also unclear how the American Medical Association and other boards of physicians will act under political pressure from anti-abortion activists. Third, the really good news is that this is not 1973. The availability of first trimester medicated abortion, or the Plan C pill, as it is also known, is a game changer. Anything beyond the first trimester will still need surgical intervention, but the bulk of abortions are first trimester. The Plan C pill can also be mailed, unobtrusively if necessary, to addresses in states that have banned abortions. These could be sent from out of state or even from a different country. The recipient won't be legally protected, but it will be hard to enforce anti-abortion laws that require looking through mail.
Mouth to mouth, going house to house, word is out. Now it seems focus is on me, dare I speak. You should know I took her.
That's all for this episode. You've been listening to I Hate Politics. I'm Sunil Dasgupta. Music for this episode comes from the Treading Lemmings, a Rockville-based Britpop band. If you want to share your music on the show or know someone else who might want to, please email us at ihppod@gmail.com or reach out on Twitter at ihppod. I hope you'll subscribe and share the show as we bring you stories about politics close to you and to your home. The Maryland primary is Tuesday, July 19th. Be sure to vote. See you next time.
Far away.